Hello, my beautiful wound weirdos. Well, I consider myself one. Welcome back to Diabetic Foot Files, where we save limbs and pretty much, I guess, wound care is more than a hobby, than an exception. It's actually a movement, to help save limbs. That's what we're all here for. And today, one episode isn't really for patients. It's for us to walk the walk and talk the talk, right? And I know everybody's, like, looking at the episode, like, saying the title, "Talk Dirty to Me," right? But, wound care is actually a language, and I don't wanna hear you say, "Oh, it smells really bad. Oh, it looks really bad." I'm like, "Okay, and, like, gotta talk to me, use your words," right? And these words are how we relate what's going on to the other physicians, right? And then these words are also in our boards. You have to remember that. And you're going to have to know how to describe the drainage or how it looks in the proper medical terminology. So, using the words properly, the right medical terminology in wound care can make a break and makes a whole difference and also allows the other specialties like infectious disease to like understand what's going on. Because I remember infectious disease doctor knew me from my notes because I was like very detailed in my notes, and he was just like, "Oh, you're that doctor," and I was like, "Oh, cool! I didn't know anybody even read our notes." But you know, it's the words. We gotta speak through our words, and the words that make the notes sound like we know exactly what we're doing, right? And know that you're probably board certified. So this isn't a romantic language, of course, but we are talking dirty. We're not just saying, "Oh, it looks like it has a little bit of pus," We're gonna have to say words like necrosis, pus, gas, ischemia, the vocabulary of limb loss, right? And if you can't use the right vocabulary, it shows that you're not the best physician, right? In my opinion, you have to use the right lingo. And I remember my attendings would want me to use the right lingo. They want you to know that your medical knowledge is superior and that you can relate it to the other physicians, okay? So let's deep dive into it, okay? So how cells die, because that's what wound care is about, right? Cells dying. So let's start on a microscopic level because wounds don't just fail dramatically, they fail cell by cell, right? So autolysis. What is autolysis? That's self digestion. So your own enzymes are quietly dissolving the tissue. Heterolysis. This is when bacteria brings their own enzymes to the party, and they're not the politest guests, okay? But they're breaking down stuff from their with their own enzymes, the bacteria, heterolysis. Cytolysis means that the cell membrane has been ruptured, okay? The cell didn't heal, it exploded. Pykonosis, and let me just spell that for you, Pyknosis, is nuclear shrinkage. The cell is giving up. Kera Keratolysis is nuclear fragmentation. It's breaking up. Karyolysis is nuclear dissolution. The DNA is gone. Oncosis, the cellular swelling before necrosis. So the cell drowns before dying. Aponecrosis, that's one I always remember, is like apoptosis, which is like auto death, plus necrosis. So it's like controlled death meets chaos. Oh my gosh. Coagulative necrosis is ischemia, like a signature of ischemia. And it's like a structure preserved, but the function has gone wrong. Liquefactive necrosis is infection driven melting. So the pus replaces the tissue. So that's something that we see a lot, like in gas gangrene, liquefactive necrosis. Caseous necrosis. This is rare, but boys love it. It's like the tuberculosis style cheese death looking, okay? And then fat necrosis, I mean, I don't know, really, to be trauma, injection, pancreatitis. Fat doesn't really forgive when it comes to that. So, infection, words that we could say during infection. Suppurative means pus, suppurative. So let me just spell that. Suppurative. Suppurative. That is a word that you're reaching, like, not to say yuck, but it means pus, okay? Exudative means a protein-rich inflammatory fluid, okay? Phlem Phlebonius infection is diffuse and spreading. It's not a capsule, but you know how we say phlegm, right? So Phlebonius infection is a diffuse and spreading. Septic focus is the source. So it'll be like, oh, we found the septic focus. Bacteremia, that's a name, that word that we know very common, is bacteria in the blood. Bacteremia, kind of even a diagnosis, bacteremia. Septicemia is the body is on fire, pretty much. Not like literal fire, but the systems are shutting down, okay? Py, py, Pymemia, Pymemia is a septic emboli flying out of an abscess, okay? So let me just spell it because I'm pretty sure I'm not pronouncing it correctly. Pymia. Pyemia is septic emboli flying out of an abscess, okay? Toxemia is pretty much the poison is circulating in your body, your blood. Endotoxemia is endotoxemia is gram-negative chaos, in my opinion, and fulminant infection moves fast, indolent infection lies, and then there is smoldering infection that pretends to behave, but it's like smoldering underneath, okay? Now, gas. If you ever feel crackling underneath your feet, right? Not say underneath your feet, underneath your fingers, like fluctuance, right? That's one thing I think of when I think of gas, fluctuance. That's the first word I think of. And so pneumatosis is gas in the tissue, pneumatosis. Subcutaneous emphysema, that's something that you'll see a lot during X-ray findings, or do they? I don't know if they say that in, I think they might say that even in the CTs. I think they do say that in CTs, that even in the X-ray. Subcutaneous emphysema is the gas underneath the skin, and that is a medical emergency. You got to take the patient to the OR, and you have to open them up, incision and drainage and whatever other surgical planning that's needed. Myonecrosis, muscle death. Clostridial myonecrosis is gas gangrene, something where, as wound care providers, we're very well versed in. Crepitant. Oh, so the word crepitus. They're gonna be like, do you hear crepitus? Yeah, it's like crackling, like, you know. But crepitant necrosis means that the tissue is rotting with the gas. Then another thing that we use with gas description is facial plane disruption. Okay, facial plane disruption. That means it goes gas really does travel through the path of least resistance, and it's going to be along the fascial plane. Okay, sometimes you're going to have to do a fasciotomy too. Okay, necrotizing fasciitis. I think everybody knows that term. Okay, but it's like a surgical apocalypse pretty much when you have necrotizing fasciitis, but those are the words. Pyomyosis is a muscle abscess. Septic thrombophlebitis is an infected clot. Okay, some of these words make me a little tongue-tied. So let's do other words to describe depth, space, and other things. So interfascial extension means it's traveling sideways. Deep space infection means it's in the compartments. The compartments are involved. Plantar aponeurosis involvement is very limb threatening. When you hear that term, yeah, very limb threatening. Tenosynovitis, that's an infection in the tendon sheet. Osteitis is bone inflammation. Osteomyelitis, I think y'all know that. I wonder if wound care providers can go in the Guinness Book of World Records for saying osteomyelitis for the most people in the world in their whole entire lifetime. Osteomyelitis. Cortical erosion means that the bone is being eaten away. You'll see that. Sequestrium, medical students know this. Sequestrium is the dead bone. I always get tongue tied with this one. Involcrum. I'm just going to spell it with you. Involucrum. And that is the body trying to wall off the infected part. Okay. Like it's dead a little bit. Not a little bit, but it's actually dead. A sinus ostium is an opening of a tract, okay? And then subperiosteal abscess, that's an abscess that's hiding underneath the periosteum, okay, of the bone, okay? Now, when we're talking about blood flow, we don't just say, "Oh, the circulation is bad. It's really bad. I'm just looking at you." I mean, we have to learn how to speak to physicians and we have to learn how to speak to patients because you can't really use too much with patients because they're not going to understand. And then sometimes people feel ashamed to say, "Hey, can you explain that further? I don't know what that means." So you have to be able to break it down to a point where anybody can understand it. But when you're talking to another physician, and on your boards, they're gonna use all these big words because you're supposed to know it, okay? So, like I said, when you're talking about blood flow, you're not supposed to say, "Oh, the circulation is bad," okay? Are you talking about electrical circuits? No. So, hypoperfusion. What does hypo mean? Below, right? So, hypoperfusion means that there is inadequate blood flow. Critical limb ischemia, that term is that means that the limb is in a threatening position where it doesn't have a good amount blood flow. It's actually a diagnosis too. Chronic limb threatening ischemia. I think they changed the term from critical limb ischemia to chronic limb threatening ischemia, CLTI. I feel like that's a more correct term that is being accepted now. Chronic limb threatening ischemia over critical limb ischemia. Microangiopathy means small vessel disease. End Endorisis obliterans is the vessel obstruction. Reperfusion injury is damage after flow has returned. No reflow phenomenon is when perfusion failure happens despite the patency. Venous hypertension, that is what causes venous ulcers. Status dermatitis, and that's like the inflammation and the color changes that happen secondary to venous hypertension and what patients get a lot when they have venous ulcers as well. Lipodermosclerosis, those are scars that usually happens because of inadequate vascular status, okay? I think that helps. Now, when we're talking about biofilms, bacteria actually has like, in my opinion, has like two personalities. Sometimes they act good, sometimes they act bad, right? Because you know how like the doctors say, "Oh, it's gonna take all the bacteria out of your gut." So there are good bacteria and there are villain bacteria. Okay, so platonic bacteria they float freely. Sensile bacteria they hide into the biofilm. Quorum, sensing, those one that means it's trying to communicate. Extracellular extracellular polymetric substance, that's like the armor of the bacteria, like phenotypic resistant means it's not genetic, it means that that bacteria actually learned a certain type of behavior to become resistant. Polymicrobial synergy, that means that the bacteria is working, like, has a teamwork, they're working in a team. And you know what's kinda sad? I feel like bacteria kinda get along better than humans, okay? Like, they work together to survive for each other, that's crazy. But humans can't do that? Yeah, we gotta do better in world. But that means polymicrobial synergy, that means the bacterias are working in a team, okay? And they're gonna cause more damage, okay? Saprophilic colonization, that means that it feeds on dead tissue, okay? And that's why we debride. Now, I feel like everybody knows some of these surgical languages, but let's keep it quick. Sharp incisional debridement. You're gonna have to say that a lot, especially on surgical consents. Sharp incisional debridement to viable bleeding tissue. Doesn't that sound? Don't you sound smart when you're saying that? I mean, like, during residency, that became second nature. I don't think I went a whole any day without saying that. Tangential excision, that's layer by layer. Fascectomy means that we're removing the fascia. Myectomy means that we're removing the muscle. Ostectomy means that we're removing the bone. Sequestrectomy means that we're removing the dead bone. Guillotine amputation, I mean, it's going to be emergency and open, but I think everybody has an idea what a guillotine is, right? Guillotine. And delayed primary closure, that's a term that we use a lot. That means we're going to wait until the infection is controlled to close it. Okay. So we're not going to suture it up right after we open it. We're going to leave it open until the infection is fully controlled and there's no devitalized soft tissue anymore or devitalized soft material. Okay. So things that cause the wound not to close. Or we're just talking like this is a little bit also like microscopic level, little bit succinct fibroblasts. They don't work. Impaired angiogenesis, that means that you're starving the tissue of the blood. Protease dominant wounds, that means that the extracellular matrix is destroyed. Inflammatory arrest, that means that the wound is trapped in that inflammatory stage. Growth factor resistance, that means that it doesn't have the growth factors and it becomes a chronic wound. Hypoxic wound bed, that means that the wound bed cells are suffocating because they're not getting enough oxygen. Dysregulated matrix remodeling, that's usually associated with scarring. Okay. Now, systemic failure. Let's do some quick words. Catabolic state, that means that the tissue is breaking down. Protein energy malnutrition, that happens a lot with diabetics as well. Uremic wound environments, that causes poison. Hyperglycemia toxicity, that's associated with diabetics as well. High blood sugar can cause toxicity. And then advanced glycation end products, and that ruins like the collagen. So, I mean, let me do like a quick thing. So don't say pus, you say purulent exudate. Don't say it smells bad, you could say it smells putrid. There's a putrid odor or fetid odor, okay? Don't say there's black stuff on the wound. When it comes to that, I know we did a black toe manifesto, but you're saying black stuff. Is it a scar? Is it gangrene? But is it ischemic? Is it demarcated? Things like that. So let's just say it was a dry eschar with ischemic demarcation. You could say, don't say there's yellow stuff on top of it. What are you talking about? No, you're supposed to say there's slough or fibrinous debris. Don't say it's just red and swollen. You're supposed to say peri-wound erythema with induration. Peri-wound erythema with induration. Don't say it's squishy. Say that there is fluctuance concerning for the abscess, okay? Don't say I hear crackles, okay? You say that there is crepitus. Don't say it goes in deep. Say it is a full thickness wound with undermining or tunneling or tracking, and it depends in which direction, proximally, distally, laterally, medially. If it's undermining, you have to go like around the clock. So it's like 3 o'clock to 6 o'clock if it's undermining, right? Don't say you say it's bone infection when you're talking to a regular person, but if you're talking to other physicians and when it comes to bones, you don't just say, oh, it's bone infection, you say osteomyelitis with cortical erosion. That's what it's gonna say. Don't say it's bad circulation. Remember, we say it's chronic limb-threatening ischemia. Don't say it looks dirty. You say it looks critically colonized. Don't say the antibiotics are failing. You could say biofilm-mediated phenotypic resistance. Doesn't that sound cool? Do not say it's not clean. You could say that the wound requires sharp excisional debridement, and don't say that the patient is a bad healer. I don't know why I said that with so much oomph. Don't say that the patient is a bad healer. Say catabolic state with impaired angiogenesis. Uh-huh. Voila. Okay, so now let's do some quick terminology questions that could be board related. So, okay, a diabetic patient with a plantar ulcer on compression A thick yellow-green opaque drainage is expressed with a foul odor. Which term best describes this finding? Is it A, serious exudate, B, serial sanguineous exudate, C, purulent exudate, D, colonized drainage, or E, fibrinous drainage? It says thick yellow opaque drainage is expressed with a foul odor. What does that sound like? Sounds like pus, right? So it would be C, purulent drainage, because purulent exudate is thick, opaque drainage because it's composed of neutrophils, bacteria, tissue debris, and I would say it's of infection until proven otherwise, okay? Now, next question. A foot infection is described as diffuse spreading inflammation without a discrete abscess cavity. Which term best applies? A, suppurative infection, B, a phlebotomous infection, C, an encapsulated abscess, D, a liquefactive necrosis, or E, septic emboli. The answer is B, a phlebotomous infection. So if it's diffuse spreading inflammation without a discrete abscess cavity. So like phlegm, that means it's like diffuse and spreading. Suppurative, that means it's pus forming. So just know that in mind, okay? So that's why we're using phlebotomous infection over suppurative because they didn't mention anything that would seem like there was pus present, any purulent drainage present. And abscesses are usually encapsulated. So I wouldn't say that either. So, because they said without an acid, okay? Next question. A heel wound emits a strong putrid odor. There is black tissue present. Which process is most likely occurring? Is it A, colonization with Staphylococcus epidermis, B, aerobic cellulitis, C, anaerobic infection with necrosis, D, venous dermatitis, or E, autolytic debridement? Which one do you think is actually the process that's most happening? A heel wound emits a strong putrid odor with black tissue present. What do you think it is? It's going to be C. It's going to be aerobic and not aerobic, forgive me, anaerobic. I'm going to repeat that again. Anaerobic infection with necrosis. So the reason why we think anaerobic is because putrid putrid odors, these fatigued odors, are usually anaerobic metabolism plus necrotic tissue. Okay. Colonization really doesn't produce a putrid odor. Colonization happens all the time with just regular bacteria. Okay. Next question. A wound has dry, black, leathery tissue firmly adherent, okay, to the wound bed without drainage. Which term most likely describes this very accurately? Is it A, slough, B, fibrin, C, an eschar, D, liquefactive necrosis, E, granulation tissue? Answer is C, eschar. I remember when I was a student and I saw eschar for the first time, and I was just like, it was like, I told, I went to the doctor, and thank God for these kind people to be so, like, I wouldn't say humble, but they were like weren't mad at me for not knowing, and then they taught me, and I never forgot. Whatever they taught me, I never forgot. But I was just like, "It's like a big black scab." That's what I told the doctor, and he just looked at me, and he's like, "You mean eschar?" And I was like, "Huh? What is that?" But that's what an eschar is. It is dry, black, leathery necrosis, okay? And just on a side note, what would you use on that? Especially because it shows that there's probably ischemia and necrosis going on there. A lot of people like to use Santal or autolytic debridement. Sometimes you can use sharp debridement too, but Santal, also honey works really well on eschars too. So eschar is the term for a dry, black, leathery necrosis. It is like a big scab, but it's not a scab, okay? Sloth, and just know, I think everybody knows the sloth is. Sloth is that yellow, like it looks like fibrin-like material, okay? But know the distinction. So there is a palpation of the diabetic foot, and the physician feels crackles beneath the skin. Which term do you think that is? The medical term for that? Is it A, fluctuance? They have crackling. B, crepitus, C, induration, D, edema, or E, maceration. It's B, crepitus. Crackling equals crepitus. That's the medical terminology. Crepitus means gas in the soft tissues, and honestly, that's going to be necrotizing infection until proven otherwise. And keyword with that, if I hear somebody says there's crackling or fluctuance or subcutaneous emphysema, I'm like, I guess we're gonna go to the OR. When's the last time you ate? That's the biggest question to the patient. When's the last time you ate? Because you're going to the OR. Okay, next question. A wound extends beneath intact skin edges circumferentially, but has no discrete channel. What term is that? It extends underneath the intact skin circumferentially. That means it's like a circle underneath the skin. It's not really intact. But let me just make it quick. It's undermining. We all should know that. Undermining means there is tissue destruction underneath the wound edges, okay? Tunneling means there is a narrow channel in one direction, okay? Next, a metal probe contacts hard tissue in the base of a diabetic foot ulcer. What is the most appropriate interpretation of that? Honestly, I think everybody should know this. Osteomyelitis until proven otherwise. Positive probe to bone test has a high specificity, but osteomyelitis, as we all know, especially in diabetic foot ulcers, if I can probe, and honestly, I don't do the whole like use a cotton swab or anything that is wood related. Use something stainless steel and you can probe it. I usually use a curette or a pickup, and that's stainless steel, and then you can, like, if you can tap and go through it. Because another thing about osteomyelitis, it loves to try to heal fragilely. It's fragile granulation tissue over it to hide, and honestly, you can poke through it. If you shouldn't be able to poke through healthy granulation tissue that's actually gonna make skin. Fragile granulation tissue over osteomyelitic bone is just really fragile, like, you can poke through it like paper, okay? So if that's happening, most likely that's osteomyelitis, and you probably have to remove that piece of bone, which, ugh, gotta tell the patient that you have to remove a piece of their bone. Which term best replaces us saying bad circulation, and let's make it board quality noted. Is it A, saying peripheral edema? Is it B, saying chronic limb threatening ischemia? Is it C, saying venous insufficiency? Is it D, saying dependent lumbar? Is it E, saying diabetic neuropathy? The answer is B, chronic limb threatening ischemia. Okay, that is the modern term today. Okay, chronic limb threatening ischemia. Now, next question. We're almost done. A chronic wound fails to improve despite appropriate antibiotics. Sharp debridement results did improve it. Which mechanism explains this? Is it A, antibiotic allergy, B, phenotypic resistance? Is it C, endotoxemia? Is it D, hematogenous spread? Or is it E, poor lymphatic drainage? The answer is B, phenotypic resistance. Okay, biofilms exhibit phenotypic resistance. That's not genetic resistance, phenotypic resistance. That that usually requires mechanical disruption, which is what we do is sharp excisional debridement, right? Of any devitalized tissue until healthy bleeding tissue. So next phrase, which phrase best documents proper sharp debridement? Saying A, the wound is clean, B, necrosis removed, C, debridement performed, D, sharp excisional debridement of viable bleeding tissue, or E, dead tissue scraped. And please don't do that. Answer that we want, the boards want, and I think even insurance wants to hear sharp excisional debridement to viable bleeding tissue. Okay, that sounds like you know what you're doing. Okay, we want viable bleeding tissue. That confirms the adequate depth of your debridement and that you remove pretty much all the devitalized soft tissue, right? And material. Next question. Which of the finding confirms infection rather than colonization? Is it A, presence of bacteria, B, positive culture, C, host inflammatory response, D, biofilm formation, or E, moist wound bed. It's going to be C, host inflammatory response, because infection is a bacteria plus host response, okay? Next is, I said I was almost done. I'm almost done. Which systemic condition most impairs wound healing? Is it A, controlled hypertension, B, normal glycemia, C, protein energy malnutrition, m- D, mild edema, or E, intact sensation? It's going to be C, protein energy malnutrition that causes impaired collagen synthesis, impaired angiogenesis, and immunity. I know all this can get anybody tongue-tied, So another question, which term should trigger immediate surgical consultation? A, malodorous wound, B, purulent drainage, C, crepitus, D, slough, or E, colonization. That's why I said in boards, it's a bunch of right answers, but what is the best right answer? And this is C, crepitus. Remember I said, if you hear crepitus, crackling, that means gas. That means most likely it's necrotizing infection, anaerobic. We gotta go to the OR. We gotta open it up. Next question. A chronic wound remains stuck in the inflammatory state, and we know that. Which term best describes that? Is it A, desiccation, B, inflammatory rest, C, autolysis, D, angiogenesis, E, reepithelialization, which is a term I love to say on my patient's notes, reepithelialization. Oh, I miss charting. I love charting on the EMR. Okay, the answer is going to be B, inflammatory arrest. Next question, which term nah, we're not gonna do that quick question. So that's it. So, if you don't name it correctly, you can't treat it correctly. And if you don't know how to name it correctly, you actually don't even respect it or you don't even know the language of the one. And it can escalate. So I hope everybody liked this episode of Talking Dirty Wound Care Style. Okay. And I hope we can communicate better with each other in a more educated medical terminology way. And this is Dr. G with Diabetic Foot Files. I hope everybody has a great Friday night and take care of your feet because they take care of you.